First of all, a very big thank you to all our respected speakers from around the world, Dr. Elaine Cole and Dr. Mansoor Khan, and from London and from United Kingdom, Dr. Michael Sugru from Ireland, and Dr. Carlos from the Philippines. I think there were some wonderful lectures on the challenges we face today in terms of the training of our fellows and residents, the training requirements, the training needs, which are pretty different because we live in different environments and we live in different milieus of care. Nonetheless, I think that's why gold standard courses are made. That's why gradually the teaching paradigms change in various ways. We had a wonderful lecture highlighting the MSc in Trauma Sciences by Elaine Cole from London, where she told us about the major trauma system existing in London and how this MSc's program is not only helping them, but also helping the various other fellows from the world to gain knowledge and skills in trauma care. And we had the wonderful Mansoor Khan, once again, a wonderful speaker, eloquent speaker, talking about the definitive surgical trauma skills, DSTS. Once again, I'll clarify, it's not DSTC, it's DSTS. And again, the concept of a physiological surgeon. And I think a very, the final talk by Dr. Michael Sugru, highlighting the emergency general surgery and how generally general surgeons, even in Asian countries, especially in India, surgeons who are into elective practice would focus more on their elective practice, doing minimal access, colorectal, breast, or endocrine surgeries, and would not venture much into emergency general surgery because that is then left to the junior most residents or resident doctors to take care of, even in teaching hospitals. So that's a big gap which Dr. Sugru and others involved in the emergency general surgery, and now worldwide we are seeing that the trauma surgeons are taking up emergency general surgery gradually because they're trained to do more and more emergency surgery. So I must thank some wonderful set of experiences and also a good highlight of the various courses which are running around the world. I would just let the ball rolling because we've just about 15 to 20 minutes to discuss in open forum. I'll probably set the ball rolling by asking Dr. Sugru about his initial, although he did talk about the emergency general surgery registry. As Dr. Sanjay already commented, we had the Australia-India Trauma Systems Collaboration Project, in which we did a minimal data set for trauma registries, which is a clinical quality registry where we had mentioned the timelines also. But that was a bilateral, bi-national, collaborative effort with the governments of both sides, the departments of science and technology, pooling in money for that project. So we did not have much problems in terms of the clearances as far as the data sharing is concerned. But a lot of concern nowadays is being raised, at least in India, I can tell you, about sharing data of your patients with the other countries. Even if de-identified, it requires a certain set of confidentiality. It requires a certain set of issues to be addressed by the local government or the national governments, and clearances have to be taken. So did you run into bottlenecks, Dr. Sugru, regarding all these issues? So at the most, what we can do is that we can join the registry, but give you summary statistics of whatever you require. We would not be able to give you raw data or anything like that, even if it is an AI platform. So Dr. Sugru, I would like to ask you if you had run into such problems with different countries, if at all. I'm not sure if he's here, but if Dr. Sugru is not around, then I would like to ask our fellows from the Asian countries, Dr. Carlos in Philippines, could you share your data, raw data with the other countries or your data of emergency management or emergency issues? Or do you have certain regulatory bodies sort of regulating the exit of data from the country?
Data management, sir, for patients. Can you clarify the question? Sorry.
So registries generally would require a certain set of data to be shared, especially if it is an international registry. There are certain set of confidentiality involved with it, certain set of rules and regulations which each country has regarding the sharing of data. We have very stringent rules in India about sharing of data, raw data with any other. So we need to have clearances and all that. Does any other Asian country, or I would ask then Sri Lanka and other people also, if they have certain rules and regulations for sharing sensitive data, patient-related data?
Yeah. Yes, we also have this data privacy and confidentiality law actually in the Philippines, that you cannot share sensitive and confidential information to others. No? So if you're talking about the cases that we can share in the data victim bank, no, we can actually just remove the personal identification for patients and just the conditions of their injuries. No? So I think that would be easy, and it will not violate any data confidentiality. You're not divulging any private information. No? So it could be possible to do that.
Okay, well, great. Any insights from Sri Lanka? Dr. Jayasundara or Dr. Amila? Yeah, Dr. Kamal?
Yeah, Prof. Hamid, I think the removing of personal identification is a must. And there is no regulation or rules, as far as I know, to share the scientific details of the patients to an international sort of a research or an audit. But it's simply we can get the permission if there is something from the ministry, and the college will involve it, as far as I know. But removing of personal identification is a must, even for death panel reviews or MNM as well. So that is the most important part. Otherwise, the scientific data we can use as far as.
Yeah, I mean, obviously, the identification of data is a definite must, even for if you're utilizing it within your country. But certain countries like India do have rules and regulations for sharing raw data, even de-identified, on an international platform. You need to take clearances. With that, I'd like to ask if Amila has any questions for the panelists or the actors.
Yes, and that we have seen that wonderful courses that all around the world administering currently. That we have got a skill courses and decision-making courses. What I want to ask from our elite speakers, what about human factor? There's human factor courses are coming as a sole courses, but what about these human factor incorporating into the current DSTS and the other courses run by the societies?
Dr. Mansoor, I think, would be able to.
Yeah.
Thanks, Dr. Amila. I think that's a really interesting question, having run a few human factor courses. And I'm going to say something controversial. When we're talking about trauma or emergency surgery, it is pointless having human factors if you can't actually do the clinical intervention. It's very good to talk about it, run a team, but if you lack the skill, the expertise, and the confidence and the competence to manage these patients, you can run as many human factors courses as you want to. That patient's outcome cannot change. So what you fundamentally need to have is knowledge, ability, teamwork, and on top of that, think of the human factors as the final touches for how you actually overview it. Because I'll be honest with you, if you can't operate, you can give me all the human factors courses in the world. It will not make me operate any better, and that patient's outcome won't be any better. So yes, I know there's a big vogue. This is why I love controversy in promoting human factors and how we speak to each other. But you know what? You need to be able to do your job first, and then that is an integral part of it, but it's no point concentrating on that if you can't do it. So I'll go back and sit on the fence again.
I think, Dr. Mansoor, I agree with what you say. Absolutely. There's no issue of controversy here. But secondly, it's very difficult in a capsule course or a short-term course to have all these things, sort of, it's just impossible. You can concentrate on a couple of issues like skills and knowledge and skills. And that's why majority of the internationally accepted courses would have that void. But I think the human factors could be along with the training of fellows or residents where they're having. And I think it should be sort of mandated, and all of us sitting here are faculties somewhere or the other, to introduce such human factor courses in their regular training programs, whether it is undergraduate or postgraduate or fellowship trainings. I think that is, and that also needs to be reiterated. There's a lot of iteration of human factor issues we see on a daily basis here for our residents also. You have a great session of 2 days on human factors and communication skills and soft skills. And after 6 months, they would, because of the work pressures they are in, they would need again a dose of, and then the majority of the residents are a fleeting lot. They would come here for 6 months or in 9 months or in a year, and then they would go to some other place. So I think that has to be factored in some long-term courses. The short-term courses, although they can discuss maybe in about half an hour that these factors are important, but to incorporate them as full-fledged, sort of sessions would be very, very difficult. I entirely agree with you, Dr. Mansoor.
So further to that, Dr. Amit, it goes back to what I said on my slide. It's you train the system, you don't train the individual. If you've got a system process in, you can put any person into a system, they will flow through it. Whereas if you stick to individuality, it won't happen. My only apprehension to this is there is a lot of talk about human factors in isolation as if it's the golden bullet. But what you do need to have is an actual holistic approach to all of these factors. And as you say, bring it in together. If you have a trainee brought in for a few months, they may not get the best exposure to it. But if every place is doing the same thing, it's a continuum, is what you actually get.
Another question to Professor Mansoor Khan, that we have got a unique medical student trauma training program in Israel. I have seen 1 week fully fledged and dedicated trauma training run by in the Hadassah by Avi. So what's your idea about how we have to incorporate trauma training into the medical student? Is it necessary, and how much emphasis we should give it? Because Israel is a different context, and they definitely need the trauma emphasis. What's your idea?
Thanks, Dr. Miller. I think ideally what you want to do is when you run a course, you want to have as many different individuals from different areas of practice as you possibly can. But in reality, the practicalities are, if you have too many people, you have too much noise, it dilutes the experience for the individuals there. So you need to hit the Goldilocks zone of what to teach and who to teach it to. With regards to medical students, take, for example, I think a fantastic course for medical students would be Stop the Bleed course. There is no point teaching them advanced airways, advanced vascular interventions, because they won't have the regular exposure. As I said in my talk, if you teach a course won't teach you how to do it. You then need to go away and practice. So if I'm teaching medical students all these high-end trauma interventions, it's going to maybe be 4 or 5 years before they go and practice them again, which may be actually not the most optimal use of resources. So target what you want. So I think for medical students, Stop the Bleed course, absolutely. Basic life support, absolutely. How to recognize the ill patient. Those are the fundamental courses, because without the basic courses, you can't build advanced knowledge. And the courses will allow them to go and practice. With the DSTS, we regularly have observers. I have anesthetists present, emergency department physicians, operating department practitioners, theatre nurses, ED nurses. They all come in and observe what the surgeons are doing so they can get an idea of what is happening in the surgeon's mind when the person comes into the emergency department, what the surgeon is going to do. And that bit of knowledge is fundamental, because they then can understand what the surgeon's thinking is. And I think if you put together everything we have been talking on, what it does actually highlight is all of these courses allow exposure to understand what different folk are thinking in different environments, if that makes sense.
Yes, thank you, sir.
I think I would compliment Dr. Carlos also. A wonderful presentation, Dr. Carlos, on the Emergo train system concept and the training program therein. We've got many training programs again on contingencies or hospital contingency planning or disaster preparedness as a part of developing the HOPE course along with Dr. Teddy Harboza long time back, 2001, 2003. And I also attended a couple of slightly longish term courses in Israel, where they also train about at Rambam about the mass casualty incidents. But from your presentation, it seemed that this is a very, very well structured course, and finally, probably they have nailed the way of sort of teaching disaster preparedness. Tell me more about the course in the sense that obviously it does teach you a lot of softer skills about decision makings, about the incident management system or incident command system. How many days would it require, and would it require the people from there coming in, or now we can have or share such a course in Asia also? So for the benefit of our Asian counterparts, can we replicate this course, say in India or any other place, or do we have to go there and take this course?
Well, actually, in the Emergo train system, there's, I think, South Korea is also a training country for Emergo train system. I think the UK is also a country. So they have many training institutions all around the world already. And the Philippines is about to be one of them also. And of course, India and Sri Lanka and Malaysia and Indonesia can also be trainers for, and you trainers for disaster using the Emergo train system. If you want to be accredited with them, you have to, of course, train to any existing accredited institution, and that's it. No? Regarding how many days, no? If you want to do your programs on your own, you can actually develop them on your own. But if you want to undergo a training for trainers or senior instructors training, there is a standardized program in Sweden for that. But they also have that now in other training institutions. So you can train in South Korea, you can train in the UK. No? So that's basically how you can use ETS also in your countries to train your responders in disasters.
Yeah,
but if you want to visit the Philippines, you're very welcome.
Thank you so much. It's my desire to come over to Philippines someday. Yes, I was, so courses like this, including the DSTC, I was actually discussing with Tariq Razak and Tina Garder this in Vienna, that even if you teach DSTC case scenarios, it's always better that you also have case scenarios from the countries in which you're teaching, or from the countries where that the problem or the doctors are getting trained. So he had an opinion that why don't we make a sort of a bank or question bank or case bank for different countries and different scenarios and different regions, and add them onto the DSTC course. I agree that if it is happening in Philippines, you need to have disaster scenarios or situations which are akin to your place, or hazards which are more in your place than anywhere else. I think that's it. Dr. Amila, would you like to finally have some word in the open forum?
We have had today, that's a great the forum about discussing about the various courses covering from the disasters to the basic training to the registries, and my great gratitude to the invited speakers for supporting the ACT in our endeavor to propagate the trauma knowledge. Thank you all. Thank you.
Over to the hosts. I think it's time to appreciate and recognize the participation of all our participants.